पीयूष सर बकुला बकुला है आज.
So we are live.
Yes, sir. Very good evening, everyone, and welcome to all residents, senior residents, and everybody who's tuned in after a very successful PG case presentation on glaucoma last month. We have some lovely cases today on developmental anomalies, and we have two fantastic junior residents, Dr. Shruti and Dr. Samiksha, who will be presenting on two cases. They've been ably mentored by Dr. Sohail Khan, again from Government Medical College Nanded, and Professor Rajesh Joshi and Dr. Wadhwani from Akola Government Medical College. We have two excellent faculty, national as well as state. Our own Dr. Jatin Ashar, who's a leading corneal surgeon. He was trained at RP Center, and then I was fortunate enough to have him as my senior colleague at LV Prasad while he was doing his fellowship, where he later joined in as consultant as well, and now practicing in Mumbai in anterior segment, leading anterior segment surgeon in Mumbai. And we have Dr. Vishal Rawal, who's alumni of two of the biggest institutes in the country, trained at Sankar Nethralaya in vitreoretinal diseases, and then serving as consultant at LV Prasad earlier in Vijayawada and now in Hyderabad at Car campus since many years now. A very well-known person in not just the field of retina, but ocular oncology as well. So a big welcome to both of you all, and thank you very much for being here. We also have our president, Dr. Shirish Thoratsa, who's always there to encourage the residents. So we'll head on to a few opening remarks by Shirish Thoratsa, and then hand over to our dynamic moderator, Dr. Archana Vare, who very ably puts everything together. So Thoratsa, would you like to address?
It's okay, Vishal. I really thank Dr. Piyush sir and Dr. Archana madam for creating this PG program so nicely. We're lucky to have Dr. Vishal Rawal, who is national faculty in retinal oncology, and our own Dr. Jati. Thank you very much for sparing your time. All the best to Shruti and Samiksha.
Thank you, sir.
Thank Dr. Rajesh. Yes, Dr. Rajesh. Yes, Dr. Sohail Khan and Dr. Sadiq. I'm proud to say that they are all from Akola, and they are a very popular teacher among their children. Over to you, please.
Archana madam, shall we begin the cases?
Yes. So good evening, everyone, and thank you, Dr. Piyush and Dr. Thorat sir. And today we have two cases, and both the presenters, they will get 30 minutes. So we'll start with Dr. Shruti. So Dr. Shruti she will present her case, and then she will be asked questions by Dr. Vishal and Dr. Jatin. And at 8:30, Dr. Samiksha will start presenting her case. So the first case is case of iridofungal coloboma. It is one of the most frequently asked cases in your MS exams. So very important case. She is JR3 and she's from Dr. Shankarrao Savan, Government Medical College, Nanded. And her mentor is Dr. Sohail Khan, who is Associate Professor at Dr. Shankarrao Savan, Government Medical College, Nanded. So, Shruti, please start sharing your screen and start presenting your case.
Yes, ma'am. Should I start, ma'am?
Yes, please start.
Good evening, everyone. I, Dr. Shruti Jadhav, presenting a case of iridofungal coloboma under guidance of Dr. Atul Raut sir, Professor and Head of Department, Dr. SAGMC Nanded, and Dr. Sohail Khan sir, Associate Professor, Dr. SAGMC Nanded. Informant being mother, a 6-year-old female child, a resident of Nanded, brought by parents with complaint of abnormal looking black part and diminution of vision of right eye since birth. Her parents give history of abnormal looking black part of the right eye since birth in otherwise apparently normal child, for which they did not seek any opinion or treatment. It is associated with diminution of vision, which is painless and gradually progressive. She has no history of any ocular surgery, ocular trauma, or head trauma. She has no history of redness, watering, colored halos, or use of any topical medication. There is no history of ocular infection and deviation of eyes or diplopia. There is no history of systemic symptoms like heart or renal abnormalities. No history of any systemic illness, fever with rash, or drug intake during antenatal period by mother. Her mother has no perinatal risk factors reported. The child was delivered full term with normal vaginal delivery in the hospital, and she cried immediately after birth. Her birth weight was 2.9 kg, and she has no history of fever with rash or any systemic illness, and there is no history of any hospital admission. She is completely immunized till date and has normal developmental milestones. The child is born of non-consanguineous marriage, and she has no history of any ocular abnormalities or genetic syndromes in her family members. The pedigree analysis of the family also suggestive of the same. A patient is conscious, cooperative, and well-oriented to time, place, and person, and she has normal general examination with no evidence of any obvious facial and dental abnormalities. Her systemic examination was within normal limits. Her head posture is normal with facial symmetry maintained. Her eye alignment is within normal limit. On ocular examination, the right eye visual acuity is finger counting 3 meters, improving to 636 with pinhole. Her left eye visual acuity is 612 and improving to 66 with pinhole. Her best corrected visual acuity in the right eye is 636 with -3 diopter sphere and -2 diopter cylinder at 110 degree. While the left eye best corrected visual acuity is 66 with -0.5 diopter sphere. Her near vision is normal and intraocular pressure as taken on non-contact tonometry is within normal limits. Her extraocular movements are full and free in all directions of gaze. Her both eyes, eyelids, adnexa, eyelashes, conjunctiva, and cornea, and anterior chamber are within normal limit. This is the slit lamp photograph of the right eye showing a keyhole defect in the iris extending from the 5 o'clock to 6 o'clock with the strands of iris stroma breaching the defect. Further right eye anterior segment examination shows keyhole defect with sluggishly reacting to light pupil, and she has no evidence of lens coloboma. Her right eye lens is clear, while the left eye anterior segment examination is within normal limits. Fundus was seen by dilating with tropicamide eye drop and examined with indirect ophthalmoscopy. Her right eye fundus shows clear media with tilted disc. Her curb disc ratio was observed as 0.5:1. Her blood vessels are within normal limit and dull foveal reflex in the right eye. There is 6 to 7 disc diameter, oval, sharply delineated, excavated lesion, glistening white in color, with visibility of underlying sclera and involving choroid. It is extending from the inferior margin of the disc posteriorly to the ora serrata anteriorly and has pigmented edges with depressed floor of the defect. These features are suggestive of Lingam-Gopal type 2 chorioretinal coloboma with no evidence of the peripheral retinal breaks. While the left eye fundus examination shows clear media with disc within normal limit and blood vessels are within normal limit. The left eye's CD ratio is 0.3:1. This is the fundus photograph of the right eye showing chorioretinal coloboma inferiorly. My provisional diagnosis is right eye typical incomplete iris coloboma with chorioretinal coloboma with anisometropic amblyopia and left eye within normal limits. The patient was managed conservatively by giving glasses for refractive correction. Her parents are educated about complications of the conditions and advised for early presentation in case of the sudden deterioration of the vision. They are advised for regular follow-up for dilated fundus examination for early diagnosis of the retinal detachment. Her parents are counseled for genetic screening and colored contact lenses were prescribed for cosmetic purpose. Thank you, sir.
Thank you, Dr. Shruti. That was a wonderful presentation, and you can stop sharing your screen. I just wanted to add one thing to your diagnosis. Your right eye also has a compound myopic astigmatism, and left eye also has myopia. So you should not miss these important findings. Okay. So I'll request Dr. Vishal Rawal to ask questions to Dr. Shruti.
Yeah, I think thank you, Shruti, for a very good presentation. I think I'm happy that at least you could reach the diagnosis. I think that's most important part. So let us go back to your presentation if you can share. I think that is very important. I think each slide, whatever you have put up, I think there are a lot of things, learning points from the resident's point of view. So coming back from the first history, I think as you kind of kindly suggested that this is a 6-year-old child, informants are the parents. So I think the most of the time, I think the parents will notice something abnormal in the eye, for which they usually come to the ophthalmologist. So in this case, as you notice, the parents notice some kind of abnormal thing in the eye as compared to the other eye, because usually they compare it with the other eye. So in this eye, they could notice the pupil was not round, or might be it is irregular, or might be the reflex was not kind of normal as was seen in the other eye. So that's what the presenting complaint why the parents came to the ophthalmologist. So I think that is first thing, which is very, very important, which you highlighted in the history. Second point, I think what I want to ask you, because if this same child comes to you and the parents are complaining about a particular appearance of the eye, especially the black portion of the eye, because they might not know what is cornea, what is iris, they don't usually give that terms. They will usually say the black part of the eye or the white part of the eye, there is something which is not looking normal as compared to the other eye. So what all things you will keep in your mind, particularly on external examination, torchlight examination, when you see this child? So what all things comes to your mind when you see this kind of appearance, particularly from the cursory torchlight examination of a child where the parents complain of something abnormal in the black portion of the eye?
Sir, any cataract, congenital cataract or
No, okay,
developmental
good. So congenital cataract, usually the parents might notice there is a white reflex. Am I right?
cataract?
Yes.
sir.
Here you are not seeing a white reflex. So that is one thing. Usually the parents might complain of white reflex. So white reflex in a child less than 5 years of age, most common presenting complaint or the diagnosis, what you should be thinking of is congenital cataract. Yes, again in the less than 5 years age group, retinoblastoma or the tumor in the eye, it is also very, very important. You should not miss that. So I think this all few things should come to your mind. Anything
Yes.
related to the birth history? Why did you ask about the birth history? What you were suspecting from the history?
Sir, any syndromic, if there is any syndromic association are present, then it is
So again, syndrome comes later. Again, there might be facial features, there might be other external examination might see you. In this child, everything absolutely okay. So birth history, what you want to look again is one thing, whether the child is preterm or normal delivery. In your case, it was normal delivery. If it was a preterm delivery and then you see this kind of thing, what you will be thinking of?
sir, it will it will point towards retinopathy of prematurity. If the child was born preterm, then there may be association of retinopathy of prematurity, which is causing also diminution of vision.
Okay. Anything else? Have you heard about persistent fetal vasculature?
Yes, sir.
Yes.
Yes, sir.
What is that?
Persistent hyperplastic primary vitreous or persistent fetal vasculature. It is also associated with, sir, white reflex of the eye.
Okay. So in that external examination, how will the cornea or what you will see?
Sir, there will be leukocoria, sir.
No, that is the reflex, what you're saying. I am saying in the external examination, cornea. So I think important point, what you want to see, particularly in the persistent fetal vasculature, is it is unilateral. Second, usually you will have one eye which will be smaller than the other eye. So here you are seeing the other eye is absolutely okay, at least externally. But this eye, you look, might be on the torchlight examination, you might feel it is a microcornea or microphthalmos. I think this is very, very important, particularly from the syndromic point of view, what you're looking at the other diseases which can present with a microcornea, microphthalmos. So I think persistent fetal vasculature is one thing what you should be thinking of, particularly when you're looking at the cursory examination. Second point, when you went to the slit lamp examination, you saw that, okay, there is a small kind of defect in the iris because pupil is not looking round. So again, what all things differentials should come to your mind when you see the pupil is not round, but it is abnormal and it has kind of particular shape?
Sir, there may be a possibility of chorectopia or pseudopolychoria and aniridia. These are associated with, sir, axon-filled chorectopia or polychoria. It is associated with the axon-filled rigor anomaly. And aniridia, it has a separate association with the other tumors in the body, sir, like Wilms tumor.
So these are all related to PAX6 gene developmental anomalies, where you see all these kind of features, particularly in the anterior segment. So what I am basically asking you, where you are seeing this kind of abnormal pupil, where it is kind of peaked in one particular sector of the iris, where you could see the iris tissue is absent. So if the question what you want to ask the parents is there was any history of trauma, because you don't know, there might be incidental history of trauma because of which there might be a traumatic mydriasis and the root of the iris might have caused any kind of damage. That's why the pupil is this kind of shape. So I think that's what you want to rule out, particularly when you see this kind of pupil, especially in a child age group. So that's very, very important. Second thing, you need to rule out the iris tissue which is absent. Is it complete or is it kind of partial? So in partial, you will see very, very minimal, the pupillary rough or the rupture or the sphincter might be a little bit of kind of abnormal sphincter rough, pupil rough might be absent in the tissue. But if it is a full thickness, then you will see the coloboma which is extending right from the pupillary rough all the way up to the root of the iris. I think that's very, very important. Next feature what you saw is in the lens. So you mentioned that lens was clear. So I think it's very, very important you do a complete dilated examination. So I think that's very, very important. Just doing because usually these pupils might not dilate completely, the pupil might be small, so it will be very, very difficult to comment on the lens, but you should be able to see is there any associated lens coloboma or lens dehiscence, or there is absence of zonules. I think these are three important points what you should be looking, particularly in a child where you see there is a iris coloboma. Again, coloboma, as you know, it is an embryological developmental anomaly. So if there is an iris coloboma, there is a very, very high likely chance that there has to be an underlying coloboma, not only in the iris, but in the lens, as well as in the choroid or the fundal coloboma. That's what you saw when you peeped inside to the eye. You saw there is a choroidal coloboma. Now, it is unlikely that you see an iris coloboma, choroidal coloboma, but there's nothing in the lens. It is not going to happen like that, because it is all kind of fissure which usually closes by 3rd to 4th, 5th week of gestation. If there is a developmental anomaly, you will see this kind of coloboma which starts right from the inferior nasal part of the optic disc and goes all the way up to the periphery, then the lens, and then the iris. So it's all the developmental anomaly. So I would say in this case, you might have missed the lens abnormality or the lens anomaly which might be present, because might be the pupil was not dilated, you will not be able to see clearly. So I think that is very, very important point which you have missed in your examination. Third point is about the coloboma. I think you kind of nicely elaborated and told us what kind of coloboma it is. So I think important point what I want you to see is what is the nature of the coloboma. So nature of the coloboma, what I mean to say, from where the coloboma is arising, what part of the eye structure it is involving. So is it involving the optic disc? Is it involving the superior margin or the inferior margin, or it is kind of separated from the optic disc? This is very, very important. So in your case, you could see the coloboma where it was?
Sir, just below the optic disc, sir.
Just
It was
below
not
the
involving optic disc. Yes, sir.
Yeah. So as per the older Edelman's classification, what type of coloboma is this?
Sir, type 3 coloboma, sir.
So what is type 3 coloboma?
There is chorioretinal coloboma inferior to the disc with normal narrow rim of tissue maintained in between optic disc and the chorioretinal coloboma, sir.
Okay. So you are seeing a normal optic disc which is there, and the coloboma is not involving the inferior part of the optic disc. That
Yes,
is
sir.
very, very important. As per the Gopal et al., you should not say Lingam Gopal. There's nothing like Lingam Gopal. Again, whenever you are kind of mentioning anybody's name, you should respect that. And you said Gopal et al. This is a study which is done by multiple authors. So always say whatever the last name of the author and say et al. So that gives a correct respect to the particular person who has done the study. So you say Gopal et al., the study which they have published, particularly because he has done more than 10 years of experience of doing or studying the all types of colobomas, and they have revised the classification of choroidal colobomas into different types. So as per the Gopal et al., which category this colobomas fits into?
Type 2, sir.
So what is type 2?
Sir, the coloboma is not involving the disc, and the disc is abnormal, sir, because the disc is tilted and the CD ratio
Very
is
good.
0.5:1, sir.
Yes, so very good. So again, so this is very, very important. You should be knowing both the classifications, that is Edelman's classification as well as Gopal et al.'s classification for choroidal coloboma. This is what usually all the examiners want you to kind of know before you go into the diagnosis. Last part, when you look at the coloboma, you should always see where it is not only anterior to posterior, but the transverse margin of the coloboma also you should be seeing. So what you want to see is there any pigmentation seen at the boundary of the coloboma? Because that's where usually you will see any kind of break or any associated retinal detachment. So you should not miss the boundaries of the coloboma. Okay?
Yes, sir.
Yes. Last thing is about the treatment, because you said for this child, we didn't do anything, we observed. So I think as per the vision, what you could see in this child, what was the vision for the right eye?
Sir, right eye vision is counting finger 3 meters and improving to 636 with pinhole.
Very good. And what was the refraction?
Sir, -3 diopter sphere and -2 diopter cylinder at 110 degrees Celsius.
So in a
10 degrees.
6-year-old child, if you have -3 and -2 kind of spherical and cylinder power, and other eye has -0.5 cylinder. So you see already there is an anisometropy or amblyopia, it's already set in. So that should also be in your diagnosis, which you have missed. So it is not just about the findings, what you're seeing, but the sequelae of the disease, which has led to anisometropy, amblyopia. I think that is also very, very important. You should highlight that in your diagnosis also. What all things you are going to tell the parents now, because this child, you have made a diagnosis of an iridofundal or iridochoroidal coloboma. What all things you are going to explain to the parents? How you are going to counsel the parents now?
Sir, the parents, I will tell them that the condition is non-treatable actually, and we can't do about the this embryonic congenital defect. And but there is risk of retinal detachment, rhegmatogenous retinal detachment in these cases.
So
There is
as
high
a parent,
incidence of.
I am going to ask: is the condition progressive? So then, what is your answer?
So the condition is as such, it is not progressive, but the vision will be getting poorer because of the amblyopia and development of the complications like the cataract rate is higher in these cases, and also there is a risk of the rhegmatogenous retinal detachment development. And so I will explain that whenever there is rapid deterioration of the vision, then they have to present early.
Okay, so I think the couple of points, I think 3 to 4 points, what you want to highlight and explain to the parents. One, as you correctly mentioned, this is a developmental anomaly. So I think they should understand that this is nothing, something suddenly it has happened. It is present since birth. Now, because of the appearance of the eye, that's why the parents have noticed and they have come to the ophthalmologist. So this is something which is present since birth. Second, you need to look at the other eye. So is it unilateral or bilateral? That is very, very important, because parents might feel it is come to one eye. Is it going to come to the other eye or not? I think as an ophthalmologist, it is very, very important. Third, as you correctly mentioned, there are a lot of complications can be associated with choroidal coloboma. So most important complication which usually comes across is retinal detachment. Again, it depends upon what kind of coloboma, what type of coloboma, and is there any associated features like intercalary membrane. So I think you didn't mention anything about intercalary membrane. So I think that is one thing you should be mentioning when you are looking at the choroidal coloboma. I can understand you might not have seen the case in that detailed examination, but I think intercalary membrane is one thing you should be looking at it, because that is one of the high risk factor for a child to develop underlying retinal detachment secondary to ICM breaks. I think that is very, very important. Have you heard about the terminology locus minoris resistance? What do you mean by?
Sir, it is the age of the chorioretinal coloboma, and these are the points where the retinal detachment rates are higher, sir.
So why it is high?
Sir, because the folding of the optic cup, the inner and outer layer of the optic cup is in a such a way that these are the points where the inner layer of the optic cup it enfolds, sir.
It's not the optic cup, it's the inner layer of the retina which enfolds, and that's why there is absence of both the retina as well as the choroidal tissue in that area. And there is a thin kind of fibrotic membrane or kind of thin membrane on the surface of the coloboma, which is known as intercalary membrane. So I think you should be very clearly looking at that membrane, whether is there any breaks in there. That if you notice any break in the intercalary membrane, what you're going to do? But there is no retinal detachment.
Sir, we can do prophylactic laser photocoagulation.
It is known as
And
prophylactic laser barrage to the coloboma. Okay.
yes.
Yes. So very good. So if you say in this case, are you going to advise prophylactic laser barrage to this child? If yes, why? If no, why?
Sir, there is no evidence of any breaks at this moment.
Very
So,
good. So that is one thing you have already find out, that there is no ICM break. So okay, there is no risk for RD. Anything else? So usually if the other eye already has a retinal detachment or there is a family history, particularly father or mother has a coloboma and they have undergone retinal detachment, then you know that this child or this eye has also high risk of retinal detachment. So if the other eye has undergone retinal detachment, even though this eye you don't have the ICM break, then also you will do laser Bharat, because particularly basically the child is one-eyed and you don't want to miss or any kind of negate that eye and say that I don't want to do Bharat because I'm not seeing any break. So I think that is very, very important. And last thing is about the counseling, about the refraction. I think is very, 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 very important. As an ophthalmologist, as a retina specialist, you might do a wonderful surgery, you might attach the retina. But again, if the correct glasses prescription or the follow-up is not done, then all the thing goes in the drain. So I think it is very, very important. You give correct glass prescription. If required to patch the other eye, I think that's what you have missed. Again, you need to patch the good eye so that this eye vision develops, because the child is still in the amblyopic age. So if you do the patching of the normal eye, there is a high chance that visual acuity might start improving in this eye also, because as I can see them from the photograph, the macula or the fovea is not involved in the coloboma. So I think there is a chance that if you do correct kind of amblyopic correction, this eye might still kind of have good improvement in the vision.
Thank you. Thank you so much, Dr. Vishal.
Yes.
And now I request Dr. Jatin Asher to ask questions to Dr. Shruti.
Thanks, Shruti. Very well presented. And I guess
Thank
Dr.
you, sir.
Vishal has almost covered the whole topic in detail. And as an anterior segment person, I would say if it was not a child and an adult, you were to have a cataract, how would you deal with the cataract surgery in a patient with iridocorneal coloboma?
Sir, in such cases, the pupil dilatation is not full, sir. So in those cases, we have to use iris hooks for the dilatation of the pupil, and also the zonular support is also weak, sir, in such cases. And we should use capsular tension ring in such cases. And the AC many a times it collapses during surgery. So we are doing phacoemulsification in such cases, we should plan for scleral tunnel phacoemulsification in such cases, sir.
So a lot of times you'll also see their microcornea, and your IOL sizing again will be a problem in these patients.
Yes, yes,
Plus, again, IOL power calculation a lot of times may not be absolutely accurate. Okay,
yes, sir.
so these are the things you have to explain a good guarded prognosis to the patient. And these cataracts are eventually way harder than what they look. That is also very important. And the anterior chamber is a very shallow, so you can use a good viscoelastic device, dispersive viscoelastic device when you are doing the surgery to prevent your endothelium from damaging.
Yes, sir.
Yeah, I think important point what Jatin raised is the corneal diameter. I think anytime you see the corneal diameter is less than 10 millimeters, I usually what we do, we don't attempt from the anterior side. It is always preferable to go from the back side and do a pars plana lensectomy and vitrectomy and do a thorough job. I think that will be helpful for the child, because doing from the anterior side, you might cause more damage to the anterior structures, especially the iris. Already there is a coloboma and the rest of the iris, if that gets damaged, you invariably causing a huge kind of glare problem or sphincter damage to pupil damage. In that case, as Jatin also pointed out, the lens is too hard. It is kind of very brown cataracts. Usually if the patients negate, they don't usually come very late for the cataract surgery and everything. So in that cases, going from the posterior segment approach will be preferable as compared to doing an anterior segment approach.
Yes, sir.
Anything else, Dr. Jatin, you would like to ask her?
I guess it's time for the next presentation.
Okay. Dr. Shruti, you have missed the fundus diagram. So you should not miss the fundus diagram because it has marks in your exam. Okay.
Yes,
So,
okay.
okay, that is one important point. And as sir said that you have missed the lens findings. So it is better to take pictures since you are presenting on an online platform. It is better to take pictures because you can't show the patient to us. So it is better to take the pictures of the profile picture of the patient and multiple pictures of the anterior segment so that we know what is the status of the lens. Okay.
Yes, ma'am. Yes, ma'am.
Okay. But overall, it was a very good presentation and you answered the questions very nicely.
Thank
So
you, ma'am.
congratulations to you and Dr. Sohail Khan also. So
thank you, MOS. Thank you, Archana Madam, and thank you, Dr. Piyush, for the opportunity.
Thank you very much.
She presented very well, Dr. Sohail. And now we'll move on to our next case. And the next case is by Dr. Samiksha. And she's JR3 at Government Medical College, Akola. And she's mentored by Dr. Rajesh Joshi sir, who is the professor and head Department of Ophthalmology at Government Medical College, Akola. And she's co-mentored by Dr. Sunny Wadhwani, who is the assistant professor at Department of Ophthalmology, GMC, Akola. So over to you, Samiksha. You can share your screen now.
Good evening. I am Dr. Samiksha. I'm mentored by Dr. Rajesh Joshi sir, HPT sir. I'm co-mentored by Dr. Sunny Wadhwani, who is assistant professor at GMC. My presentation is on a case of a 9-year-old male child who was brought by mother with chief complaints of diminution of vision in both the eyes, right eye more than left eye, since 1 year. As narrated by the child, he was apparently all right 1 year back when he developed diminution of vision in both the eyes, right eye more than left eye, which was gradual in onset, painless, and progressive in nature up to the present state. There was no history of photophobia or watering. There was no history of colored halos. There was no history of sticky discharge. There was no history of trauma in the past, and no history of swelling in the eyes. Past history suggests no systemic illness. Patient had a treatment history, went to a private hospital for the same 8 months back, and there he was given Toba eye drop BT. Birth history, preterm normal delivery was at 30 weeks of gestation. Child was ventilated for 3 days. There was no history of trauma during birth. Mother had preeclampsia during her ANC period. Personal history for sleep was adequate. Appetite was normal. Bowel bladder habits were normal. There was history of consanguineous marriage among the parents, but none of the family members had any ocular complaints. There was no developmental milestone delay. There was no musculoskeletal abnormalities in the child. The general examination showed fair general condition. The vitals were stable. A febrile pulse rate was 94 per minute. Respiratory was 18 per minute. Blood pressure was 110/70. No evidence of failure, cyanosis, clubbing, or lymphadenopathy. The systemic examination was within normal limits. On local examination, head posture was normal. Facial symmetry was normal. There was a mongoloid slant present on alignment, and extraocular movements were full and free in all the direction of areas of both the eyes. As you can see in the image, the gross image of both the eyes, the visual acuity was tested. Unaided was 1/60 in the right eye. No improvement with pinhole. The best corrected vision was 1/60. And in the left eye, the unaided visual acuity was 2/60. With pinhole, it was not improved. Best corrected was 2/60. Retinopathy could not be performed because of the corneal opacity. Lid and adnexia was normal in the right eye. Conjunctiva was normal. Sclera was normal. Cornea was normal in size. Solid, irregular surface. There was loss of transparency. Leukomatous opacity was present, covering inferotemporal and superonasal quadrants. Nebulonuclear opacity in rest of the two quadrants. There was adherent glaucoma centrally from 1 to 2 o'clock, and iridocorneal adhesions were seen from 9 to 11 o'clock. Corneal sensations were present. Anterior chamber was irregular in depth, contents could not be assessed. Iris showed iridocorneal adhesions. The pupil and lens detail were not appreciated. In left eye, the lid, conjunctiva, and sclera were normal. The cornea was normal in size, prolate, irregular surface, loss of transparency, and leukomatous opacity covering three quadrants. Macular opacity was seen in the superior quadrant. Her corneal sensations were present in left eye. Anterior chamber, depth and contents could not be assessed. Rest, iris, pupil, and lens details could not be seen. The nasolacrimal passage showed Roplast was negative. Saccharine was patent, and intraocular pressure on inflammation tonometry of the right eye was 20 millimeter of mercury, and left eye was 20 millimeter of mercury. Fundus examination with direct ophthalmoscope showed there was no glow in the right eye and the features could not be visualized. In left eye, there was a faint red glow present, whereas rest of the features could not be visualized. So my provisional diagnosis would be both eye sclerocornea, both eye Peters anomaly, both eye corneal opacity due to mucopolysaccharidosis, or both eye corneal endothelial dystrophies. Later on, B-scan ultrasonography was done, which showed normal posterior segment, but lens was subluxated, and both parents had no eye abnormality. There was no any systemic abnormality. Systemic examination was normal, but with the suspect of Peters anomaly and mucopolysaccharidosis, her per abdomen USG was done, which revealed the unilateral renal genesis. 2D echo was performed, which revealed left ventricular hypertrophy, and MRI brain was normal. And on the basis of investigation, Peters plus syndrome was diagnosed. So my take-home message would be that corneal opacity in children have a unique differential diagnosis and might be associated with systemic abnormalities despite normal physical examination. So investigations like USG, CT, MRI should be implemented to rule out syndromic association. And as this child presented at 9 years of age, it was a neglected case of Peters syndrome. Also, there was not proper uh, guidance given at a private hospital elsewhere. So there is a need of awareness and screening programs among the children. Thank you.
Good presentation, Dr. Samiksha. You could have added the pedigree chart for the patient, and in the birth history, you must mention whether the child cried well after birth or whatever. So that was missing. So I think I would like to request Dr. Jatin first to ask questions to Dr. Samiksha.
So, Samiksha, can you go back to your slides, please? To share. So you told the parents noticed it only not immediately after birth, but later on.
Parents said that there was opacity on the eye, which was not central, but there was no diminution of vision, and hence
No,
they didn't see it from the
See,
birth.
it's like since it was a 9-year-old child and you are saying it's only for 1 year,
Yes, yes.
Peter would not present at a later age.
Sir, the parents said that there was opacity, but as the child had no
No,
diminution of
your
vision,
history is clear that it was decrease in vision, but you did not mention that there was opacity that they had noticed from birth.
yes, sir, there was opacity from the birth. The parents
Have you
gave
mentioned that?
Okay.
Yeah, because the very diagnosis of Peter, which is a congenital by birth, would be challenged if you're saying it is only for 1 year, because then it will be an acquired disease, right?
Yes, sir.
I mean, as per your history, this comes to be developed at the age of 8 years. All right. Can we move further to your other slides? You again a corneal diagram or something you've drawn? So if you were to present and draw a corneal diagram, how would you put it as whether it is, I mean, you saw this child on slit lamp, right?
Yes, sir.
So how would you denote on a diagram for the leukoma? How would you make it?
Leucoma will show with the black color, and as it involves all the three layers up to the stroma, it will show with the black color in the cross-sectional diagram of the cornea.
Your findings.
So there was iridocorneal adhesions also in the right eye.
Can we go to the findings? So this does not look to be a normal sized cornea. If in the photo that you are showing, the size does not look normal. Plus, any vascularization? Or there was no vascularization in the cornea?
No vascularization was seen.
What other investigation would you do from ophthalmology point of view? You've done a B scan. Something else that you want to see?
So I would also like to do ultrasound biomicroscopy or your anterior segment OCT.
Correct. So did you not think of doing that?
Also, we couldn't do it as such, but UBM was investigated. It was patient was sent for UBM investigation.
Child looks to be very cooperative to allow all the examination, including applanation. And I'm pretty sure he would have cooperated even for a UBM.
Yes.
Because you've also done an applanation for the child.
Yes, sir. I did applanation telemetry and it showed the 20 millimeter of mercury pressure.
Correct. So if you're considering features, you would be more interested whether there is only a iridocorneal touch or also a lenticular corneal touch.
So that was only iridocorneal touch.
No, but if the opacity is so dense and you are saying your lens details were not clear, why are these two things important?
So because in ultrasound microscopy, the lens details can be very nicely seen, and also
What are the different types of features?
so types of features can be features 1 and features 2. In features 1, cornea and iris are involved, and in features 2, lens is also involved. So there will be lenticular corneal lenticular adhesions in type 2, along with zonular divisions causing lenticular subluxation or dislocation.
But if you're saying your cornea was completely opaque, in features,
Yes.
most commonly it would be peripheral cornea would be clear.
Central cornea, feature starts from central cornea and then moves
Correct.
towards the periphery.
Yes, correct. I understand, but there was no clarity of the cornea in any of the quadrants.
No, sir. There was also clarity from two quadrants in the right eye, that is inferonasal and superotemporal quadrant. In the left eye, there was only a slight clarity at the supernasal quadrant.
What other disorder would you really want to look up?
Other disorders, I would suspect sclerocornea or congenital endothelial dystrophy, like congenital hereditary endothelial dystrophy. Or
Yeah, but that would CHED would never have any additions between the iris and the cornea. Correct. What was the management that you offered to this child?
So after there is corneal opacity in both the eyes, and fundus posterior segment showed lens subluxation, but the fundus was normal. I have advised
You
him,
saw that on the B scan, right? You're saying the
yes,
slit subluxation. Do you have
yes,
the image of the B scan?
no, sir. Unfortunately, we could not acquire the image.
Then how did you see the subluxation? Was it completely dislocated? Was it only slightly subluxated? What was the subluxation?
No, sir. It was dislocated in the posterior segment. but the rest of the fundus was normal. So we could advise the patient with pars plana, vitrectomy, and mastectomy. Also,
But how are you going to see anything for doing pars plana vitrectomy?
corneal keratoplasty, penetrating keratoplasty.
Okay. So what are the problems where you can face when you're doing pediatric keratoplasty?
Whereas the cornea is totally opaque to do total penetrating keratoplasty. And
How is the scleral rigidity in children?
scleral rigidity is more in children. And there
Is
will
it
be
more in children?
as the
How is a pediatric keratoplasty different than adult keratoplasty?
age-wise donor has to be known. And there is more chance of scleral perforation while suturing.
No. Age-wise, the donor has to be what?
So age-wise donor is preferred if
What
pediatric
is preferred?
corneal donor cornea.
What age you are saying?
So as endothelium count should be considered, and as most older age groups like above 80 years, if the endothelial count is already lost, we
No,
cannot
18.
18,
18.
sir, 80, sir.
80.
No, sir, 80.
Okay. 80. Okay. But nowadays, eye banks have stopped. Most of the eye banks don't collect above 80.
Yes, sir. After doing endothelial count, if the endothelial count is within normal limits, we can go for penetrating.
What is a normal endothelial count?
Sir, at birth it is 3,000 to 4,000. At puberty it goes up to 2,000. In adult age it is 1,500 to 2,000.
Have you got your specular done? You think you will be having 1,500 endothelial count?
So in donor cornea, specular microscopy has to be done.
No. I understand. You are saying above 18 years of age, the endothelial count drops to 1,500.
It's above 18 years.
18 or 80?
80, sir.
Okay. Now I request Dr. Vishal to ask questions to Dr. Samiksha, and I thank Dr. Jatin for his questions.
Yeah, I think thank you, Samiksha. So I think most of the things, being a retina specialist, I usually come across very rarely see Peters anomaly. But yes, I think once in a while, usually we kind of have a combined approach. A cornea person as well as a retina person needs to be kind of seeing this kind of children. So I think differential diagnosis, what you kind of already highlighted, what you should be thinking when you see in a child age group, this kind of bilateral presentation with bilateral corneal opacities might be symmetrical, might be asymmetrical. But again, I think it is very, very important you do a very good corneal examination. I think that's the critical, because the rest of the examination is very, very difficult. Child might not cooperate, or you might not have all the facilities to do it. But I think a good clinical examination of the cornea, that's what it is utmost important. And that's what Dr. Jatin was kind of trying to make you understand, that just not only about the mentioning about the just opacity, that is a leukomatous or macula. It is a very, very kind of MBBS person will give that kind of answers. I think what he wanted is exactly what kind of opacity, what quadrant is there was an area of clearing, what you could see is you do you can see the any kind of iris structures below the corneal opacity or not. And about the lens, what he clearly pointed out, I think this is very, very important when you do an ultrasonography or a B scan, you look for the posterior capsular kind of hyperreflective echo, which will denote that the lens is in place or there is a subluxation. If there is a subluxation, I think you need to point out whether it is a mild subluxation or total subluxation of the lens. And last thing, what he pointed about is about the treatment part. I think it is very, very important that again, the counseling is very of utmost important for these children, because this is a kind of progressive disease, congenital. You know, this patient has been neglected and now has a systemic problem where you have renal agenesis and all kind of other systemic problems also there. So as an ophthalmologist, it is very, very important. You just don't see about the eye and you kind of satisfied with your examination and your diagnosis. It is very important that you refer the child, particularly if you are looking for a particular Peter plus syndrome where you other systemic organs also affected, and you do a good screening for all the examination. I think that's where you make you a complete doctor. Otherwise, you will be satisfied with your finding and then the child has some other underlying heart disease or a kidney disease which you have missed. I think that is very, very kind of not a good doctor would like to have that. So I think that is very, very important. And I think you need to learn more, Samiksha, especially about the specular counts, specular microscopy, how it is done. If it is not available in your institute, I would suggest go to any of the private institutes in your city, visit one of the cornea specialists and learn how to kind of not only do specular counts, but also how to read a specular microscopy kind of investigation. That is very, very important, because the answers what you gave, they were not correct. I think, unfortunately, might be you have not seen how it is done or how the report is kind of read. So I think that's a homework for you. You should be going and seeing first, because unless until you do yourself, you will not be able to learn. So I think that's the homework for you. Do a good specular yourself and read the different kind of charts, how the specular counts are done. And last thing is about the keratoplasties. Again, if you're not done, visit, or if required, go to a eye bank and see how the eye is collected, or how the organ donation is done. I think that is also a part and important part of the ophthalmologist, particularly in organ donation is a very, very important kind of clinical skill, what you should be knowing, how to retrieve the eyeball, how to cut the cornea. I think that's part and parcel of your residency. So I think make sure if you don't have an eye bank in your city, LV Prasad has a very good eye bank program. I think you can anytime visit and just write to any of the LV Prasad eye bank technicians. They'll be happy to visit, make your visit and see you how the eyeballs are retrieved and how the corneal buttons are stored in what kind of medium, what kind of examination they do to make sure that the eyeball or the corneal graft is given to the recipient in an ideal way in a proper storage medium. So I think I would say, I think a lot of things for you to learn. I think I understand this is your presentation, first time presentation or very early type presentation you're doing, but I think still a lot of learnings for you from this presentation.
Thank you, Vishal sir. I request Dr. Rajesh Joshi sir to give any comments.
Yeah, I thank MOS for this opportunity. In fact, both the presenters, they presented very well, and I appreciate both of them. Both the cases were very unique, and managing these cases, it's a difficult task, particularly in setup having a meager instrumentation. I would like to highlight on the second case about the Peters anomaly. In fact, we need to consider about the other causes of bilateral corneal opacity, like metabolic disorders and other things, like particularly in rural areas, they tend to put some drops or some medications which are harmful to the eye. That is also very important. And apart from that, parents, they should be made aware of such type of abnormalities, and they should this child should be managed properly, because they have to live long. And the management part, as far as management part is concerned, the anterior segment surgeon along with the posterior segment surgeon can help this child to regain some amount of useful vision. That is what I want to tell. Thanks, MOS, for this opportunity.
Thank you, Joshi sir. Dr. Jatin, would you like to have some more comments?
Thanks.
Okay. So I request Dr. Shirish Thorat sir and Dr. Piyush Bansal sir for the concluding remarks. Dr. Piyush? You are mute. You are mute.
Thank you, Dr. Vare. Thank you, Professor Joshi, for your very relevant comments about how things can be different in the rural areas as well. Congratulations to both of the residents. It takes a lot of courage to present cases, especially on an online platform like this, and again answer questions. So both of you all did a very good job. I think both our expert faculty did justice to their stature by not only asking the tough questions, but also explaining where their lacunae are and how they can improve on their study. So thank you very much, Dr. Vishal Raval and Dr. Jatin Asher. But most of all, thank you, Professor Archana, for guiding the entire webinar series on case presentations. So with this, I thank everyone. Professor Dr. Thorat sir, if he's there. I think we can anticipate our next series. Thank you, everyone.
Thorat.
Sir is there.
Please go ahead. Please go ahead, ma'am.
No, sir, we just need some concluding remarks from you. Actually, every time we have these case presentations and every time we also learn something from these cases,
Yes,
because the
actually,
experts are
we
so
learn-
good
Actually,
that we
this is
also
the best. And actually, this is one of the best series of webinar, a case presentation. I have followed this series right from the first, right from you, I mean, to say, right from the UAN and glaucoma, and then this series. And
UTR
every
part
time I
and
learn
glaucoma.
a lot of things from each. Yes.
Hmm.
Great, and it's really congratulations to all of you. Nice.
Okay, sir. So with this, I think we can conclude the session. Dr. Piyush, can we conclude the session now?
Yes, madam. Thank you, everyone, for starting in time and finishing in time.
Okay.
Thank you. Thank you, everyone.
Thank you.
Good evening.